invitation. I sincerely thank the Oncology National Academy for inviting me for this program. So today we will discuss about the management of HPV positive Ca Oropharynx. We know that this is a new disease entity and it is having better prognosis compared to the HPV negative head and neck malignancies, and this is another addition to the virus causing malignancy in head and neck apart from carcinoma and nasopharynx. So this will be the flow of my talk. One, the clinical presentation, how they differ from other head and neck malignancies. Number two, why this is a new disease entity and what is the evidence for the same, and what is the classification, new staging system, what is the treatment strategies in 2020, and what is the evidence for the same, and what are the future directions. So this will be the flow of my talk. So we need to understand that the HPV positive carcinoma oropharynx is on the rise. This is a data published in Journal of Clinical Oncology in 2011. This is rates per 1 lakh, and from 1980 to 2004, you can see that there is an increase in the oropharyngeal carcinoma. You can see that this is oropharynx. There is a steady increase in oropharynx rates per 1 lakh. That is from 0 to 1. So you can see that there is an increase, and you can see that the HPV negative oropharyngeal carcinoma is coming down, and the HPV positive Ca oropharynx is coming up. And when we look into from 2000 to 2030, the projected annual number of cases in HPV positive disease in US, you can see that the CA, this is the CA cervix, this is the CA cervix, this is coming down, the annual number of cases. And you can see that the oropharynx, overall there is an increase, and the oropharynx in men is increasing. Can you see that? Can you make out? So this is the annual incidence of cases. And it is not alone with the United States. You can see across the globe, there is a global trend for increase in oropharyngeal carcinoma. And also there is an increase in oral carcinoma. But in oropharynx, you can see in many countries, across the globe, in Latin American countries, in Canada, in Europe, or in Japan, Asia, you can see that there is an increase in oropharyngeal carcinoma. And this is one of the trend. And in our country also the increase there, the P16 positive or HPV positive Ca oropharynx carcinoma is on the rise. And we know that this is a new disease entity. And why it is a new disease entity? Because of various factors. Before that, we will discuss the clinical features. And in last time when I discussed about the nodal stations, I have mentioned this point. And when we compare the HPV positive and HPV negative disease in head and neck, and this is applicable only for oropharynx, we never consider or test the P16 or HPV DNA for oral cancer, larynx, or hypopharynx. This is applicable only for oropharynx. We know that the majority of the tumors, the squamous cell carcinoma in head and neck, is due to tobacco or tobacco-related products. Whereas in HPV positive, Ca oropharynx is due to the HPV, the human papillomavirus, mainly 16-18 subtypes. Mainly occurs in below 60 years, that is middle-aged man. They are the most common. It's mainly due to the sexual behavior. Field cancerization is not seen. Generally, we know that the tobacco-related malignancy patients, even after the patient is cured with Ca oropharynx, patient can come back with another primary in any of the aerodigestive tract. So that's not the case in HPV positive disease. HPV positive disease, the field cancerization is very rare, and usually they have very small primary, or the primary may not be visible, but the patient presents with lymphadenopathy, large cystic lymph nodes. Small stage, primary stage, but large lymph nodes. And the histology shows poorly differentiated histology, and is mainly the baseloid features, poorly differentiated histology with baseloid features. And this is characteristic of HPV positive Ca Oropharynx. The in situ changes are absent, or T0 is absent in HPV positive carcinoma oropharynx, but you can see that in situ in tobacco related malignancy. And most important thing is that if you look into the biology, you can see that the P53 is intact, the apoptotic pathway is intact, and there is mutations are infrequent in HPV positive disease. This is one of the features which we think that this type of tumors is having a good prognosis. So we know that sometimes you may not be able to find any primary. The patient will present with a large lobulated mass in the level 2 region or level 3 region, level 2 mainly, and with a large cystic nodes, lobulated nodes, but the primary may not be visible. And this is a small primary. You can see a lesion in the posterior 1/3 of the tongue extending into anterior 2/3, and with a large necrotic node. You can see that this is a typical presentation in a Middle East man, where this is HPV positive Ca Oropharynx. And sometimes it may be picked up when you walk up for a metastatic neck node unknown primary. You do an endoscopy, you may not find out anything. You take a CT scan from base of skull to root of neck, you will not see any primary apart from the node. But when you do a PET CT, you can see a very small tumor. You can see in the right lateral pharyngeal wall, very small tonsillar primary, the T1 with a large node. So this is one of the important presentations. So PET scan will help you to 3 things in walk-up of metastatic neck node unknown primary. One, where you can find out a primary. Number 2, you can do a biopsy. You can see an assisted biopsy. It will help you to locate for a biopsy. Third thing is that you can rule out any distant metastasis. So this is the importance of doing a PET CT. And this is another case. You can see a very small primary and patient is having a node. So these are all small presentations where you will find out either a small primary, or you may not be able to find out a primary. That may be picked up in a PET CT, or you may not be. And some certain situations you may not be even picked up in a PET CT. But when you do a choroidal biopsy or an excision by the lymph node, then it is a metastatic neck node. You do an Epstein-Barr virus assay, or you do a P16, then you will find out that this patient is having an HPV positive Ca Oropharynx. So then you will stage it as T0, or you cannot find out the primary. Then you stage accordingly. Then what is the evidence to say that this is a new disease entity, and this is what is the prognosis? This is a paper which published way back in 2008 in Journal of National Cancer Institute in JNCI, and this is a clinical trial, prospective clinical trial, evaluating the efficacy of patients, or the results of patients who are undergoing chemoradiation for HPV positive disease. So you can see that 96 patients were included in the clinical trial. These patients included Ca Oropharynx and Ca Larynx, and patients were given 2 cycles of induction chemotherapy, cisplatin carbo plus a taxane, followed by chemoradiation with cisplatin, 70 gray in 35 fractions. And with a median follow-up of 39.1 months, it has found that those patients who had a P16 positivity, that is 38 patients out of 96, you can see that the 2-year overall survival and the disease-free survival and overall survival better in patients who had P16 positive, HPV positive disease. And 2-year overall survival was 95% compared to 62%. This was quite statistically significant. And it showed that this was a phase 2 trial by the GOCT 2399. It showed that those patients who had a human papillomavirus positive head and neck squamous cell carcinoma, they had a better overall survival, 2-year overall survival, compared to patients who did not have a human papillomavirus positive. This is a landmark publication which came in New England Journal of Medicine in 2010. The RTOG 0129 was a phase 3 randomized trial evaluating the role of altered fractures radiotherapy along with cisplatin. This is a randomized trial, phase 3 trial, comparing cisplatin plus conventional radiotherapy, 70 gray in 35 fractions, versus cisplatin, 100 milligram per meter square, versus axial radiotherapy, 72 gray in 42 fractions over a span of 6 weeks. So conventional, what is the role of chemotherapy if you give axial radiotherapy. That was the main question of this clinical trial. The data was initially published in Red Journal in 2007, and there was an update with a long-term follow-up of 7.9 years published in JCO in December 2014. The clinical trial showed that there is no difference between the outcomes in terms of survival, disease-free survival, or long-term toxicity. So this was the conclusion of RTOG0129. And this was a publication. That was the human papillomavirus and survival of patients with oropharyngeal carcinoma. Almost 260 patients. The P16 assay was done for these patients. That was done retrospectively. And they have come up with a recursive partition analysis. And they have prognosticated patients into 3 categories. And what they have done, the number of patients were 260. It was all patients, there was no data for P16, but they have categorized patients into low risk, intermediate risk, and high risk based on 3 parameters. 1, whether the P16 was positive or negative. Number 2, the pack years, whether it was more than 10 pack years or less than or equal to 10 pack years. And third criteria was the stage of the disease. When they did a recursive partition analysis, it was found that those patients who had low risk features was defined as patients who were P16 positive and up to N2A nodes, and who had less than 10 packets. This is the red, and the 3-year overall survival was 94%. At the other extreme, in blue, it was P16 negative. Those patients who had more than 10 pack years and T4 disease, that is P16 negative T4 disease, who had more than 10 pack years of smoking history. These patients had a very high risk, and 3-year overall survival was 42%. What does it mean? And those patients who did not either a low risk or high risk, they were categorized as intermediate risk, and they had an intermediate prognosis. So what does it mean? 3-year overall survival, that is 94%. In patients who had N2A, this is not the new HPV classification. This is the whole head and neck. That is N2A means a single node on ipsilateral side, more than 3 centimeters, less than 6 centimeters. And up to that, the 3-year overall survival was 94%. It means it is like a potentially curable disease, like an early germ cell tumor or early Hodgkin's disease. So here, we may have to reduce the toxicity of treatment because they are going to live longer. We have achieved a plateau here. We may not be able to improve further. It may be more toxic. So why don't we reduce the toxicity by reducing the treatment for this group of patients? Here, we know that the high-risk patients, 3-year overall survival is 42%. What does it mean? It means there is a huge room for improvement. And we may have to intensify our treatment. And so these are the 3 factors to decide the prognosis. And this became the backbone of designing of further subsequent P16 positive oropharyngeal carcinoma clinical trials. I have no time to discuss all the clinical trials which has evaluated the HPV and better head and neck cause-specific survival. But I have discussed 2, one phase 2 and one phase 3. This was the RTOG0129, the Kainickal, the late Kainickal, who was the head of the Department of Radiation Oncology at MD Anderson. And this is a paper we discussed just now. And the EGOC trial, which was the 2399 that we discussed. So these are 2 papers which we discussed. When I have all clinical trials in one table, it is found that the hazard ratio of death it is like 0.2 to 0.45. Means, what does it mean? It means that those patients who have HPV positive disease, the relative reduction of death is reduced by around 50%. It means they have a good prognosis. And why they have a good prognosis? This is a very good article which came in International Journal of Cancer, which is the journal of the UICC, which came in 2014. It is the interplay between HPV and host immunity in head and neck squamous cell carcinoma. I urge all the residents to read this. The factors which they mention are the good factors for head and neck, the HPV positive disease, are discontinuity of the basement membrane in Krebs. It lead on to access to lymphatics, and new non-mutated P50, that is apoptotic pathway, is intact, so better response to treatment. There is a cell cycle dysregulation, and there is an increased G2M cell cycle arrest. So it means that the patient are more radiosensitive. And the viral antigen is producing an immunological response. And this is also having a good outcome. And what is the new staging system for head and neck, HPV positive head and neck squamous cell or oropharyngeal carcinoma? And this is based on 3 landmark papers. And one came in 2015 and 2 papers published in 2016. Again, I request all of you to go through these 3 publications. And the first publication came from the Princess Margaret Hospital, published in JCO in 2015 with a very good editorial. And the second paper, which published from MD Anderson in 2016. And the third paper was an international collaboration. That is the HPV-related oropharyngeal cancer by international collaboration on oropharyngeal cancer network for staging. ICON-S clinical trial. That is a multi-center cohort study. And Brian Sullivan from Princess Margaret Hospital, Canada, was the PI for the clinical trial and published in Lancet Oncology in 2016. And all these papers paved way for the new staging system in head and neck, in the HPV positive disease. And I'm not going into each paper, but you can see that what they have done. This is the PMH, the Princess Margaret Hospital study. They have done all, they have to taken N2B up to N2B into stage 1, and up to the N2C was considered stage 2. And the all T4 or N3 were considered classified as stage 3. When they analyzed, it was found that it has almost included 573 patients. A very good outcome compared to a HPV negative disease. Stage 1, stage 2, the graphs were almost hugging each other, and they have a very good outcome compared to stage 3 patients. More or less similar was what they have done with the MD Anderson people. But what they have done is the MD Anderson, they have done subclassified the stage 1 into stage 1A and 1B based on whether it is T1 or T2. And the T4 and N3 was classified as stage 3. And all stage 4, the patients, because when the patient had a distant metastasis, it was classified as stage 4. So coming to the classification, can I continue? Because I will take the question at the end. Is it okay? May I continue?
Yes, sir.
Okay. So we will discuss the staging. We know that up to T3, the oropharynx, it is based on the size criteria. Up to T3, there is no difference between whether it is P16 positive or P16 negative, HPV positive or HPV negative. Whereas we know that in HPV negative, see oropharyngeal carcinoma, it is divided T4A and T4B. T4A includes larynx. Suppose a patient in oropharynx going into up to lingual surface of the epiglottis, that is T3. If the tumor spreads beyond the lingual surface of epiglottis, like if the patient is having a pre-epiglottic space, I will show you cases like that, then it becomes T4A. Deep or extrinsic muscles of tongue, medial pterygoid muscle, hard palate or mandible. These two are bone, not the tumor extending mucosally, but the hard palate is involved by bone involvement or a mandible involvement. Then it becomes T4A. T4B is lateral pterygoid involvement, pterygoid plates, lateral nasopharynx, skull base, or carotid artery encasement. Prevertebral muscle involvement is not incorporated in the staging of Ca Oropharynx. That is P16 positive or P16 negative. Prevertebral muscle involvement in nasopharynx is T2, whereas in larynx and hypopharynx it is T4. So if your examiner asks you what is the stage, if it is T4, prevertebral muscle is involved in oropharynx, because you have to say that prevertebral muscle is not involved in the staging of oropharynx. And carcinoma in situ is removed because absence of distinct basement membrane in the epithelium of bladder. So this is the primary staging difference. So there is no subclassification for T4A or T4B in HPV positive disease, because when they analyzed, it was found that T4A and T4B, the survival curves were hugging each other. Then there was no difference, and they have decided that it has to club together the T4 and T4B together in the HPV positive disease. I will take a clinical scenario. This is a 54-year-old male. There was no history of any habits. You can see a lesion in the tonsil. You can see a right tonsillar pillar, posterior tonsillar pillar, tonsillar fossa. You can see a lesion extending into the tonsillar lingual surface. And this lesion was also coming to the base of tongue was also involved. This was a lesion, and the patient also had a 5 into 4 centimeters. You can see the patient had a 5 into 4 centimeter lesion in the right level 2 region. So it is a T2, and this patient and poorly differentiated squamous cell carcinoma X-ray test was normal. If the patient is P16 is positive, then it is a T2 because there is no difference, that is P16 positive, HPV positive or HPV negative. But the node, if you have a node 5 into 3 centimeters, single node on ipsilateral side in HPV negative disease, it becomes an N2A disease, and it is a stage 4 disease. Whereas 5 into 3 centimeter, single node, if none of them are more than 6 centimeters, multiple node or single node on one side, that's on the ipsilateral side, it becomes only N1. It is T2N1, it is stage 1 disease. But never think that the stage 1 disease start treat with a single modality. Because in larynx, oropharynx, larynx, hypopharynx, oral cavity, HPV negative C oropharynx, you say that if the patient is a stage 1, it is T1N0. You treat either with radiotherapy or surgery. That is not applicable for HPV positive disease. You cannot change the treatment as of now, because we know only that they have a different prognosis. They have a good prognosis. Okay. Now I will take another example. So this is HPV negative disease. HPV negative. This is a T2 disease. You can see a lesion in the lateral pharyngeal wall extending into the anterior portion of the tongue. You can see also a lesion is in the posterior pharyngeal wall, node T2N1. It is a stage 3 disease. If we have a primary in the oropharynx, this is vallicular, base of tongue going into vallicular. You can see a lesion there, a node there. You can see a necrotic. You can see cystic clinical. You can see a T2N1 disease. It's a T2N1, it's a stage 1. And this is another tumor. You can see a lesion. This patient, 51-year-old male, he's not a smoker or alcoholic, present with a lesion in the base of tongue. Can you make out the lesion? You can see that it's coming into the level of the vallicula. And also, you can see there is some enhancing lesion in the pre-vertebral space, sorry, pre-epiglottic space. So this is the pre-epiglottic space. This is the area epiglottic fold. And this is the piriform fossa, posterior pharyngeal wall. You can see an enhancing lesion in the pre-epiglottic space. So this is a oropharynx going into a larynx. So it is T4. Patient has nodes there. You can see nodes there. And it is a multiple nodes. The T4, actually if it is P16 negative, it is T4 N2B. So T4A N2B, and it is a stage 4. Whereas in HPV positive disease, it is T4, no T4 and T4B, but multiple nodes on one side, it becomes only N1. It is T4N1. That is stage 3 disease. I will give you again another example. So, where I know that there are certain first year students. For the seniors, it may be boring. If you want to teach a N1 disease, what is an N1 in head and neck squamous cell carcinoma? 3 criteria. 1, single, the node should be ipsilateral, and the size of the node should be less than or equal to 3 centimeters. That is N1. The moment you have an N1, or the moment you have a node, you are dealing with a stage 3 because it is a locally advanced. We all know that cervical lymph node is the most important prognostic factor in head and neck squamous cell carcinoma. Whereas if you have a HPV positive disease, so it is a single ipsilateral node less than or equal to 3 centimeters. Minimum stage is stage 3. Whereas even if you have multiple nodes, in the case we have seen, the node had a 5 into 4 centimeters, multiple nodes on one side. And if none of them are more than 6 centimeters, it is only stage 1. If you have nodes on both sides, then it becomes N. Whereas in multiple nodes on one side, that's ipsilateral side. And even if the nodes are below the caudal edge of the cricoid, it is only N1. I told you in last class that if you have a node below the caudal edge of cricoid cartilage in carcinoma nasopharynx, it becomes an N3 disease, and automatically it becomes stage 4A. Whereas in HPV positive Ca Oropharynx, it is only stage 1. Multiple nodes on ipsilateral side, and none of them are more than 6 centimeters. That is difference between HPV positive disease and HPV negative disease. And here, if you have multiple nodes, you have a multiple nodes, and it becomes N2C in oral cavity, larynx, hypopharynx, and HPV negative C oropharynx. And it is a stage 4 disease. Whereas in HPV positive disease, bilateral nodes, it becomes N2, and it is a stage 2 disease. We have multiple bilateral nodes, it becomes a stage 2 disease. So that is, otherwise it is a stage 4 disease. Here it is only stage 2. And here you have another case. This is HPV positive, and this, you think it is one is HPV positive, other is HPV negative. Here is HPV positive. You can see bilateral nodes. If you remember my last class, this is the hyoid bone, and this is the caudal edge of the hyoid bone, and this is a level 2 node. Okay? You may have another cut, one more cut. It is all in the level 2 region. You can see multiple nodes on bilateral nodes. And if the patient is having HPV positive Ca Oropharynx, and it becomes an N2, it's a stage 2. If you have a HPV negative disease, you have bilateral nodes. This is at the level of the level 3 because it's a thyroid cartilage started appearing. Pre-vertebral, pre-epiglottic space, paraglottic space, thyroid cartilage, and any node at the level of the thyroid cartilage or at the cricoid cartilage, I told you in the last class, it becomes a stage, it's a level 3 node. Sorry, it's a level 3 node. So bilateral nodes, so it is a N2C if it is HPV negative, it's a stage 4. So one or more ipsilateral nodes, if none larger than 6 cm, it is N1. Contralateral or bilateral lymph nodes, none more than 6 cm, it is N2. In nasopharynx, there is no concept called ipsilateral or contralateral. It is called unilateral or bilateral. Whereas ipsilateral or contralateral concept is there in HPV positive. There is no concept called extracapsular extension. There is no N3A and N3B, only N3. If nodes, even if you see nodes, I have shown you one slide in the CT scan. So in the beginning, that it was infiltrating the sternocleidomastoid, but still it is only N3 and it is not N3A or N3B. I will show you this. So this is N3. It is not N3B. It is N3 in HPV positive Ca Oropharynx. Even if you have encasement of the carotid artery, even if you have encasement of the infiltrating the sternocleidomastoid, it is only N3 and it is not N3B, and it is stage 3 and it is not stage 4. This is the head and neck squamous cell carcinoma composite stage, that is C oral cavity, C larynx, C hypopharynx, HPV negative Ca Oropharynx. The moment you see a node, it becomes stage 3. If you have an N2 node, or then it becomes stage 4 or a T4A, whereas N3 or T4B stage 4. In HPV positive Ca Oropharynx, there is no stage 4A because there is no stage 4A, there is no stage 4B, or there is no stage 4C. Any stage 4, it becomes a metastatic. Whereas if you have a head and neck squamous cell carcinoma, the metastatic disease is only stage 4C. Up to stage 4B, it is only a locoregional disease. So you may be confused with the staging of Ca nasopharynx and HPV positive Ca Oropharynx. I will try to clarify that. Moment you have a node in Ca nasopharynx, then it becomes stage 2. Any node in Ca nasopharynx is minimum stage 2. But the nodal positivity can occur in stage 1 of Ca oropharynx also. So it's up to T2N1, it is stage 1. Whereas T2N1 in Ca nasopharynx is stage 2. In T3 or N2, it becomes stage 2 in HPV positive Ca Oropharynx. Whereas the T3 or N2 in Ca nasopharynx is stage 2. Any T4 or N3, it is stage 3 in HPV positive Ca Oropharynx. In nasopharynx, it is T4 or N3. That is any node below the caudal edge of the cricoid cartilage, or any node more than 6 cm, it becomes a stage 4 disease. Whereas in HPV positive Ca Oropharynx, there is no stage 4A or 4B or 4C. Immediately it becomes a metastatic disease. Nasopharynx, there is stage 4A and 4B. There is no stage 4C in Ca nasopharynx. Whereas in HPV positive Ca Oropharynx, there is no stage 4A, 4B or 4C. there are certain situations where you come across, even in spite you do an endoscopy, you do a CT scan or MRI, and do a PET CT, then you may not be able to find out any primer. And if the node is showing a P16 positivity, then you stage according to HPV positive Ca Oropharynx. And there is a pathological nodal staging also, separate pathological nodal staging also for HPV positive disease. This is unique for HPV positive Ca Oropharynx. And this is based on the number of nodes involved and not the size. If you have metastasis in 4 or fewer lymph nodes, means the size of the node, it is immaterial. If the patient is having 4 or less nodes are involved, up to 4, it is N1. This is very important because when we discuss about the clinical trials designing in the surgical setting, it is important. N2 means metastasis more than 4 lymph nodes. And size is not a criteria, 1. Number 2, extracapsular extension is also not a criteria. Multiple nodes and one of them are having an extracapsular spread in oral cavity, it becomes an N3P disease. Whereas even if the patient is having say 2 nodes and both of them are more than 6 centimeters and both of them are having extracapsular extension, still it is PN1 and there is no PN3 because there is not based on any size or extracapsular extension. So the pathological this, and there are certain group, especially the EGOC, still practice in oropharynx surgery. So this is pathological nodal staging in HPV positive. So how the treatment? Now we are coming to the treatment. We know that HPV positive oropharyngeal carcinoma has better prognosis and they have a very good outcome, survival, and more than 90%. We need to long-term morbidity associated with the current treatment will be longer lasting. So can we reduce the treatment? Can we consider de-escalating treatment regimes? That what we have followed for Hodgkin's disease, germ cell tumors, etc. In the same way, or a low risk ALL. In the same way, can we do the same in the de-escalating treatment regimes for HPV positive? Before coming to the treatment, first we need to understand the markers, HPV markers. So when a patient, when there is an HPV infection first, and this will lead on to what? The viral integration. Viral integration occurs, that integrates into the DNA. Then you can find out. Then it occurs when it integrates with the DNA. What happens? The viral transcription occurs. Viral transcription occurs. Then the E6 mRNA, and this is the mRNA form. Then it will lead on to transcription will become translation. So the E6 mRNA produces E6 protein and E7 mRNA produces E7 protein. So first occurs the transcription. Then if you want to diagnose at this level, then you have to do a DNA. You can say DNA in situ hybridization. And if you want to know this mRNA, you can do RNA in situ hybridization. Then the other thing is that you can evaluate the proteins. And E16 protein interacts with the P53. And the P53 and the retinoblastoma gene, they are tumor suppressor genes. What happens? The E16, the translational protein, binds with the P53 and the retinoblastoma gene. And what happens is it produces a tumor suppression inactivation. The pathway is blocked. So what happens? The cell cycle arrest does not occur. So this progression of cell cycle lead on to a protein called P16 protein. So what happens? This can be assigned. So it means this pathway is activated. And you can estimate the P16 and you can this can be considered as a surrogate marker. This estimation is done by a P16 immunohistochemist. If you want to, this is a very beautiful article which published in the American Journal of Surgical Pathology in 2012. And I've taken diagrams from that. So if you are interested, you can go back and you can read this article, excellent article, which discuss about the pathogenesis of HPV disease. So P16 testing with immunohistochemistry reported higher sensitivity, specificity is 79%, higher rates of concordance with the high-risk HPV DNA, is easily available, sites and around 7% will not correlate with HPV. And this is in guidelines. This is the American college. This is from the College of American Pathologists. And this was endorsed by the ASCO, published in Arch Pathology, Archives of Pathological Laboratory Medicine in 2018. And this was an endorsement by ASCO, published in 2018 in JCO in October 2018. So this is a very busy slide, so I will try to describe this. So if you have an oropharyngeal primary, so please be with me for a few minutes, because then it will be very easy for you to read this article. So if you have an oropharyngeal primary, all patients should have a P16 assay. If P16 is positive with more than 70% nuclear and cytoplasmic staining, that is called P16 positive, then you consider as primary oropharyngeal carcinoma, and it is considered as this HPV positive. Whereas if you do not satisfy the criteria, like no staining or less than 70% nuclear and cytoplasmic staining, you consider it as HPV negative, and you will not consider any further test like HPV DNA. This is non-oropharyngeal primary, like oral cavity, larynx, and hypopharynx. Can you mute, please? Thank you. If you have a non-oropharyngeal primary like oral cavity, larynx, or hypopharynx, there is no need to do a routine HPV test. Okay. Now I will discuss two other clinical scenarios. You have multiple tumors. So tumors involving multiple sites. Like we have seen a tumor like the base of tongue, vallicula extending into pre-epiglottic space. You can have a tumor in larynx going into oropharynx. So in that situation, suppose you do not know whether it is a oropharyngeal primary or a oral cavity primary or larynx primary. In that situation, you do a P16 IHC. Then if you have no staining, like you consider it as HPV negative. But if the patient is having P16 positive, like positive with more than 70% nucleus and cytoplasmic staining, then you proceed with an HPV specific test. It is applicable for this and also for a cervical lymph node evaluation. And if it is positive, then the HPV specific testing, then you consider it as HPV positive disease. And that is applicable for lymph nodes also. If you have lymph nodes, you have lymph nodes and involving level 2 or level 3. Because if it is clinically apparent primary, then yes, then if oropharynx, then you do PC. But you cannot make out where the primary is. Then it's pharmaceutical custom of unknown primary, level 2 or lymph node group. If it is level 4, no need to do that. If it is 1B, no need to do that. If it is level 2 or level 3, then you do a P16. If it is P16, and if it is negative, you consider it as negative. If it is positive, say if it is level 3, then if it is level 2 or level 3, do a P16. If it is negative, then negative. If it is positive, and if it is non-keratinizing morphology, then you consider it as metastatic. Then you consider it as metastatic squamous cell carcinoma HPV positive. And if it is no, non-keratinizing is not, it is not non-keratinizing, no, then you have to do HPV specific testing. And if it is positive, then you stage it as HPV positive. If it is negative, you consider as HPV negative. There is no need to do a grading. So in oropharyngeal primary, always you have to do a P16. If you have level 2, level 3 metastatic neck node, unknown primary, or tumors involving multiple sites, you do a P16. And in that two situations, if you come across a P16 positive, you have to confirm with a definitive test. If it is negative, that's negative. In non-oropharyngeal primary, you do not need to do a routine HPV positive testing. Now coming to the treatment. So what are the treatment strategies? For most of these patients present with lymph nodes, and T1N0 or T2N0 presentation is very less. So most of them present with like treatment with advanced disease. Oropharyngeal carcinoma generally treated with non-surgical treatment, but we have data coming up for early oropharyngeal carcinoma, RT basis transoral robotic surgery. I will discuss that later. When we consider chemoradiation, what are the strategies? We know that for an oropharyngeal carcinoma, if this P16 is negative, standard treatment is to consider concurrent chemoradiation. It's the standard for locally advanced. So the main concerns are whether we can reduce the morbidity of long-term toxicities of concurrent chemoradiation. The different strategies has been tried. One, shall we replace the cisplatin with cetuximab along with radiation? Second, can we give 2 to 3 cycles of induction chemotherapy? Then can the radiotherapy dose can be reduced? Can we reduce the dose of radiation at the same time reduce the dose of chemotherapy also? That is CTRT with decreased RT and chemo dose. The fourth question is that can we omit chemotherapy in at least in low risk patients? Like we have seen that low risk patients 3-year overall survival was 94%. Can we reduce or can we omit chemotherapy? Then can we use protons instead of photons? Then can we reduce the long-term morbidity? Then the last one is, can we consider less invasive surgery? And you tailor the adjuvant treatment based on risk stratification. So we'll discuss each one by one, but most of these de-intensification strategies are in the pipeline. Either phase 2 or phase 3 trials are underway. And only in the first situation that replace cisplatin with cetuximab, we have a phase 3 data. We all believe, as oncologists, believe that we have a good phase 2 data that set a platform for designing a good phase 3 trial. And we will not change the treatment based on a phase 2 data. So first concept is that replace cisplatin with cetuximab. We all know that this may be, except maybe a first year or a second year residents, many of may be knowing this trial. This was a clinical trial, that's a Bonner trial. This was a clinical trial published in New England Journal of Medicine in 2006 in February. This was a phase 3 randomized trial comparing radiotherapy plus cetuximab in locally advanced head and neck squamous cell carcinoma. And the patients were randomized either to standard radiotherapy or standard radiotherapy. There is standard radiotherapy or either it is a conventional radiotherapy, altered fractionation, or radiotherapy plus cetuximab. This was a update of the clinical trial which published in NEJM in 2006, updated in Lancet Oncology in 2010 with a 5-year follow-up. It was found that those patients who received cetuximab in addition to radiotherapy had almost a 10% increase in 5-year overall survival compared to patients who received radiotherapy. And they have come up with a subset analysis, but this was an unplanned subset analysis. So the data should be interpreted with caution. And the patients who benefited most from cetuximab was patients who had oropharyngeal primary, patients who with excellent performance status, patients who received altered fractions radiotherapy, that is increasing number per fraction, and patients who are males. So male patients, oropharyngeal primary, good prognosis, good performance status patients, and who received patients who received more than 1 fractions of radiotherapy had a better outcome. But this was an unplanned analysis. And there was no phase 3 trial comparing cetuximab plus radiation basis cisplatin plus radiotherapy at that time. So the biggest question which is evaluated across the globe was, can we replace the cisplatin with cetuximab? 2 attempts, 2 major attempts, 3 attempts, but 2 has been published and 1 is underway. And one from the RTOG, that was the RTOG 1016 clinical trial, and second was the de-escalate from the UK, that is the de-escalate HPV clinical trial. There is a slight difference between the inclusion criteria and the primary endpoint of these 2 clinical trials. I will discuss these 2 clinical trials in detail because both of them were published. Both of them published in 2019, the first month of January. And in the RTOG 1016 clinical trial was presented in Astro Annual Meeting in 2018 and published in Lancet Oncology in 2019. And the paper was published online towards the end of 2018, but came officially in 2019. And this is the de-escalate was a UK trial. That is, both of them are a phase 3 trial. The difference between this was, in the UK trial, they include only low risk patients. whereas in RTOG 1016, the clinical trial included the low risk and intermediate risk patients. We know that once the patient is having high risk, it becomes P16 negative. So low risk and intermediate risk patients of oropharyngeal carcinoma were included. And there was a difference. In the UK trial, the primary endpoint was toxicity. In the secondary and in the RTOG 1016, it was primary endpoint was overall survival. There was slight difference in the design also. And the RTOG 1016 was designed in a non-inferiority fashion. Whereas this is mainly the evaluating the toxicity part, the UK trial. So I will discuss first the UK trial. This is a number of patients were less compared to the RTOG 1016. The 348 patients were randomized either to standard chemoradiation, cisplatin plus radiotherapy, or cetuximab plus radiotherapy. It was the 100 milligram per meter square, 70 grain 35, cetuximab 400 milligram per meter square, loading dose, 1 week prior to radiotherapy, and followed by concurrent along with radiation, 250 milligram per meter square weekly. And this was include only low risk patients. The primary endpoint was toxic. There was no difference between the toxic. It is the overall grade 3 or grade 5 toxicity, and secondary outcomes were the acute and severe toxicity. Late toxic, there was no difference between them. Data was published in 2019 in Lancet with a median follow-up of 22 months. It was found that the 2-year overall survival was better in patients who received cisplatin compared to radiotherapy. And same is applicable for recurrence also. And both of them are statistically significant. The conclusion of the de-escalate low risk was because it included only low risk patients. HPV positive patients had good prognosis. There was no difference in toxicity between the two arms. Better overall survival and less recurrence in patients who received cisplatin compared to cetuximab. Even in low risk patients, the cisplatin plus radiotherapy remains the standard of care. And the second is the RTOG 1016 clinical trial. The primary endpoint was overall survival. The non-inferiority margin was defined at 1.45, which included more number of patients, almost 1,000 patients were randomized. Similar fashion, low risk and intermediate risk patients were included, published in Lancet in 2019. There is a difference in toxicity profile. And in the UK trial, there was no difference in toxicity profile. But in the US trial, you can see that mucositis, skin reaction, and rash were more in patients who received cetuximab. Whereas the hematological toxicity, renal impairment, and hearing toxicity were more in patients who received cisplatin compared to cetuximab. And if you look into the 5-year overall survival, it was better in patients who received cisplatin compared to cetuximab. And it did not. So you can see that this is significant in the progression-free survival was also better in patients who received cisplatin compared to cetuximab. And if you indirectly compare these two trials, it was found that the de-escalate trial, it included only low-risk patients. Primary endpoint was toxicity, median follow-up was 22 months, whereas the long-term follow-up is seen in RTOG 1016. Primary endpoint was overall survival. Number of patients were more. There was a difference in toxicity, and both showed there is better survival with cisplatin compared to cetuximab. The second attempt was to give induction chemotherapy and then you reduce the dose of radiation. And this was evaluated initially in the EGOC trial 1308 clinical trial published in JCO in 2017. All patients were received induction chemotherapy with paclitaxel, cisplatin plus cetuximab, given 1 to 3 cycles of induction chemotherapy. Then patients, it was a prospective observational study, single arm study, and the patient who achieved complete response after 1 to 3 cycles of paclitaxel, cetuximab, and cisplatin induction chemotherapy were given 54 gray. Means the patients who received good response with induction chemotherapy reduce the dose, that is 54 gray in 27 fraction along with cetuximab. Or you give those patients who had a partial response or stable disease received full dose, that is around 70 gray, 69.3 gray in 33 fractions with concurrent cetuximab. The primary endpoint was 2-year progression-free survival. 80 patients were included in the clinical trial. And when the data was published in JCO in 2017. It has found that its 2-year overall survival was 94%. And 2-year overall progression-free survival, 2-year old. This was overall, sorry, this patient had, this is a patients who had all patients put together. This one 2-year overall survival was 94%. What they evaluated, those patients who had good prognosis, it was found that 2-year overall survival was 96%. So the conclusion is that we may be able to reduce the dose of radiation if you give induction chemo. But we need to be tested this particular hypothesis in a phase 3 fashion. This is a quarterback clinical trial. This is a phase 3 clinical trial which is underway, and the PI is a Marshall Posner. You may remember that he was the PI for the famous TAX 324 clinical trial. And at that time, he was in Dana-Farber Cancer Institute. He moved to Mount Sinai Hospital in New York. And this is a phase 3 trial. And the patients with stage 3 and stage 4 patients in P16 positive patients are randomized. After 3 cycles of induction chemotherapy with TPF, those patients who achieve CR or partial response are randomized. So patients who achieve CR or PR are randomized either to give the standard 70 grain 35 fractions with concurrent carboplatin weekly AUC 1.5, or you reduce the dose of radiation from 70 to 56 grain to 28 fractions with the same concurrent carboplatin. And this is underway. And this trial, we may give you some direction that whether we can reduce the dose of radiotherapy from 70 to 56 grain in patients who are receiving 3 cycles of induction chemotherapy in P16 positive Ca Oropharynx. The third concept is that can we reduce dose of radiation and chemo both together? And this is an attempt from North Carolina group, published in What Journal in 2015. This was phase 2 trial, de-intensified chemoradiation for favorable risk of human papillomavirus, such as oropharyngeal carcinoma. Although they mentioned the favorable group, this is up to T3 to N2 patients were given. It was a single arm study. Patients were given 60 gray, that is reduce the dose from 70 gray to 60. Then the weekly cisplatin dose from 40 to 30. The primary endpoint was complete response. Median follow-up was 14 months, and the patients, 98% of the patients, and 98% there was a CR rate in the primary and 84% for the nodal. There are some pitfalls for this clinical trial because they include very early patients also, that patients may not need chemotherapy. Second, it was a short-term follow-up, 14 months, and it was a planned neck dissection. At that time, in many US and in the European groups used to do planned neck dissection, means in N2 or N3 disease after chemoradiation, patient used to undergo planned neck dissection. To rectify this, then they are conducting a phase 2 trial. These patients can be given weekly chemotherapy. That is, there are 4 choices are there: cisplatin 30 to 40 milligram per meter square, cetuximab, carboplatin, or paclitaxel. And then the chemotherapy will not be given for early disease that is having a good prognosis. The dose is 60 gray. Again, single arm observational study, prospective observational study, 60 gray in 30 fractions, 2 gray per fraction. This is underway. The third concept is, another move is, can we reduce the oleum, that is reduce dose and oleum, that is I said dose, and they randomize patients into low risk patients or high risk patients. And the patients received the carboplatin plus nab-paclitaxel as induction chemotherapy and 3 cycles. And after that, the patients were the low risk patients or high risk patients, based on response, they have given chemoradiation. In those patients who received good response, that is low risk patients with 50% response, received only subsequent radiation, or patients with high risk features which receive response between up to response between 30 to 50. The high risk patients with 50% response, or low risk patients with poor response receive chemoradiation, and patients who have less response, like in high risk patients. In high risk patients, if the desired response was attained, then the patient received full dose of chemoradiation. And based on this strategy, the data was published in Annals of Oncology It was found that those patients who had low risk features, you can see that the progression-free survival was 100%. And you can see that the low risk features, the overall survival was 100%, and the progression-free survival for high risk features was 94, and low risk it was 95. The overall survival in low risk it was 100%, and high risk it was 97%. It also works, but we need a phase 3 data. Third is in low risk patients, those patients who have good prognosis, whether can we avoid chemotherapy and treat with radiotherapy alone. And this is an ongoing clinical trial. This is a HN1O002 clinical trial. Those patients have good prognosis. Patients are randomized to receive radiotherapy alone, that too 60 green therapy fractions. Or you consider that dose of radiotherapy with weekly cisplatin 40 milligrams per meter square. The conclusion is that the main aim is whether can we omit chemotherapy in patients with good prognosis. The next attempt is, can we replace protons with photons and reduce the long-term outcome? The MD Anderson group is running a clinical trial evaluating this hypothesis. A phase 2 trial is underway. The IMPT basis, intensity modulated proton therapy basis, intensity modulated radiation in patients who have a P16 positive Ca Oropharynx, and it is randomized to IMRT or IMPT. Again, we need more follow-up. Again, we have to wait to have results of this phase 2 trial. The last one is the less invasive surgery. Can we use, this is a hotkey. There are 3 hotkeys in head and neck. One is immunotherapy. Second is HPV positive Ca Oropharynx. The other is the protons, and the other one is the transoral robotic surgery. And can we replace radiotherapy with a transoral robotic surgery? This was a question. This was a phase 2 trial. This is called the Orator trial. This was an initiative of the Cancer Institute Canada. This was published in Lancet in 2019. And this was a phase 2 trial. The primary endpoint was a swallowing related quality of life at 1 year based on the MD Anderson dysphagia inventory score. If the 68 patients were randomized either to 34 randomized to radiotherapy, 68 patients were randomized to radiotherapy or transoral robotic surgery plus neck dissection, transoral robotic surgery plus neck dissection. You can see that, okay, would you repeat what is low risk in this ongoing clinical trials? Low risk is patients, we have seen the patients who have P16 positive, patients have small primary and less than 10 pack-years, and size was up to N2A. That is considered a low risk. And the 34 patients are allocated to radiotherapy group and 34 into the surgery. It was found that although patients were allocated to surgery, subsequently, only 10 patients received surgery alone, and 16% received surgery plus radiation, and 8 patients had to receive surgery plus chemoradiation due to poor prognosis. So what does it mean? Mean that then you entered with giving multiple therapies. So it means it is more than single modality. So when you need to consider the efficacy results, the overall survival and progression survival, you can see that the 2 graphs are hugging. There was no difference in the outcome. But when they evaluated, the primary endpoint was swallowing related quality of life. When they evaluated, these were all in favor of patients who received radiotherapy. I won't advocate, or I won't say that radiation is superior than transoral robotic surgery plus bar minus adjuvant treatment. For that, I need a phase 3 trial. I do not argue without evidence that, although I am a hardcore believer of radiotherapy. So the conclusion is that the swallowing related parameters are better in patients who receive radiotherapy compared to, you can make out that from this graph. So from this chart. What about the P16 negative patients? And there was a phase 2 trial that is called the RTOG 1221 clinical trial were randomized to chemoradiation or transoral robotic surgery plus this was based on surgery plus neck dissection plus or adjuvant radiotherapy, but this trial was closed due to poor patients. So how you argue for radiation, how you argue for surgery? How you argue for radiotherapy? It is a well-established approach in early oropharyngeal carcinoma. Functional outcomes are better. It can be done for all patients. It can be done for tumors very proximity to critical structures as well. IMRT has definitely a potential to reduce toxicity in terms of acute and long-term dysphagia. And you can treat retropharyngeal lymph nodes when you treat with radiation. There is no steep learning curve is required, but there is a steep learning curve is required for transoral robotic surgery. My real concern is if you take the patient for transoral robotic surgery, that should be the end of the treatment. If you feel that this patient becomes a candidate for radiotherapy, either due to close margin or not positive, then that patient should be treated with radiotherapy. That's the gist. Now, coming to the surgery adopted, if those patients who are undergoing transoral robotic surgery, there are three clinical trials underway. Two of them are phase 2 and another is phase 3. So post-operative adjuvant therapy de-intensification strategy for human papillomavirus patients, that is the DOP. And these patients who have T1 to T4 patients Ca Oropharynx who achieve a negative margin. And if those patients who have extracapsular spread in their nodal metastasis are randomized to either give standard post-op dose of 60 gray or 60 gray plus a weekly cisplatin. The main aim is to know that if those patients have extracapsular spread in their node metastasis, where the chemoradiation is beneficial compared to adjuvant radiation alone. We know that in extracapsular spread in head and neck squamous cell carcinoma, there is a benefit. And we are testing whether this is applicable for P16 positive patients as well. The next clinical trial is a GOC 3311 clinical trial. It has already accrued around 500 patients. Those patients after surgery were randomized to low risk, intermediate risk, or high risk. Low risk patients were observed. Patients who have single node positive disease, margin negative, then they are observed. Those patients have high risk features like is defined as node positive disease, positive margin, patients who have extracapsular spread more than 1 mm, or PN2 means more than 4 lymph nodes are positive. These patients are given 66 gray post-op dose plus 66 gray in 33 fraction plus concurrent cisplatin, 40 milliamp cisplatin. And intermediate risk patients are randomized either to give 60 gray or 50 gray post-op dose. The primary endpoint of this is to evaluate 2-year progression-free survival and also to quality-related issues. The third clinical trial, this is again a phase 2 trial. The Pathos clinical trials are randomized to intermediate risk patients and high risk patients. High risk patients are patients who have margin positive more than 1 mm, extracapsular spread, or patients who have more than 4 nodes positive. And high risk patients are randomized to adjuvant radiation 60 gray versus 60 gray plus 14 milligram per meter square. That is the same features, same design compared to the first clinical trial, that is this one, the same clinical trial, same design. Low risk patients are randomized either to 50 gray or 60 gray. All the clinical trials are underway. So far we have been discussing. So to conclude, we know that the HPV positive Ca Oropharynx is having a good prognosis, number one. They have a good outcome. The various de-intensification strategies are underway. The 2 phase 3 clinical trials are available. We are not in a position to say that we can replace the current treatment as of now. Cisplatin plus radiotherapy is the standard of care. We have phase 3 data compared to cetuximab plus radiation. Regarding surgery, Orator clinical trial, it is a phase 2. We have seen that the number of patients who require surgery alone is few. Majority of the patients being randomized to surgery have had to undergo a surgery plus adjuvant program. But we need a phase 3 data to say that this transoral robotic surgery is equivalent to radiotherapy, or radiotherapy is inferior, or radiotherapy is superior to transoral robotic surgery. Coming to the future directions, we know that the immunotherapy is also a hot cake. This is a phase 2 trial, which is incorporating ipilimumab plus anti-PD-1, that is nivolumab, in combination with radiotherapy. This is again a phase 2 prospective observational clinical trial. Why they have incorporated ipilimumab and nivolumab? Simple reason: to tackle two pathways. I will show you that. Second, both of the molecules are from the same. This is what is PD-1 and PD-L1. We need to know that this is the PD-1, that is a programmed cell death protein. That is the PD-1. So this is the PD-1. You have a ligand. This is that is present in the tumor cell. That is called the PD-L1. That is a programmed death ligand 1. That is CD274. And the program, this is the PD-1. That is the CD279. So we know that so many CD15, CD30 like that. The CD279 is programmed. That is PD-1. So PD-1 is present in the tumor cell. That is a T cell. And the T cell. Then the PD-L1 that is present in the tumor cell. So when they bind together, what does it have? What happens? It causes an inhibition of tumor cell. So when they bind, this is a PD-1 and PD-L1 bind together, there is an inhibition of tumor cell. Or there is, what has happened? It inhibits the apoptosis. When you incorporate an antibody, that is either a PD-1 inhibitor or a PD-L1 inhibitor, then this inhibition of the tumor cell is inhibited, or the pathway is reactivated. So what is then second pathway? This is the pathway. This is the dendritic cell. So we are taking care of the microenvironment. This is a T cell, and the B7. Can you make out this? This is the pathway. This is the ipilimumab. So this is the pathway PD-1 nivolumab acts. So this is where the nivolumab acts, and this is where the ipilimumab acts. So combining these two, and you need to understand that mainly this pathway, the B7, that is this pathway is activated mainly in the lymph nodes. So this is the one acts in the primary tumor, another acts in the lymph node. The primary tumor microenvironment and the PD-1 or a PD-L1 inhibitor. So here this is the nivolumab. The other is the pembrolizumab. Pembrolizumab is also PD-1 inhibitor. So the nivolumab and the pembrolizumab is many clinical trials are underway incorporating chemoradiation, and this is mainly tackling the tumor microenvironment. This is the dendritic cell. This is the lymph node. This is the anti-CL4. This is the ipilimumab. This is ipilimumab is an anti-CTLA inhibitor, 4 inhibitor, whereas the nivolumab is anti-PD-1. So the T cell activation by ipilimumab at the site of the lymph nodes, and nivolumab it occurs at the primary tumor. So we are coming to the conclusion part of my discussion. So we need to understand that can we replace cisplatin with cetuximab? Two negative clinical trials, the de-escalate and RTG1016 clinical trial, and the other attempt from Australia, the TUR-OG5 clinical trial is underway. We are awaiting the results. Second strategy, can you mute please? Second strategy is, can you reduce the dose of radiation? Please, can you reduce the dose of radiotherapy after induction chemotherapy? Phase 3 trial, the quarterback clinical trial is underway. Can we reduce the dose of radiation and chemotherapy? 2 positive phase 2 trials, and another phase 2 trial is underway. Can we omit the chemotherapy? A phase 2 trial is underway. And can we evaluate the protons? Can we use protons instead of photons? The IMPT basis IMRT clinical trial by the MD Anderson group is underway. And can we tailor the treatment, adjuvant treatment after transoral robotic surgery? 1 phase 3 and 2 phase 2 trials are underway in post-op setting. This is one unpublished data from our institution. We have evaluated around 400 patients. It has found that the incidence of in oropharynx around 30%. It's an unpublished data in oral cavities around 6%. So this you can go through the NCCN, the latest NCCN guidelines published online in June 9th of this year. This is the version second version in 2020. You can standard treatment is in early disease, either you give radiation or surgery. Uh, I believe more in radiation because that's why I said radiation or surgery, T1 or T2 and C. In all other advanced disease, standard treatment is to go for radiation. Always you have an option of surgery followed by adjuvant. Thank you very much for your patient listening. I'll be very happy to share my slides. This is my WhatsApp number. This is my email ID. You just send me an email saying that you need this, because I have updated a few things. I know that I have sent this presentation, but I have made few minor changes in the later in the today. So if anyone wants, you can have it. I'm happy to take few questions. Please type me.
Thank you, sir. Thank you so much. It was really a wonderful presentation. We can have questions from the house.
Please type. Okay. Okay. Regarding the HPV, so many people will ask me that why don't you do a in situ hybridization for all patients? It may not be possible. Number one, P16 we can do by immunohistochemistry, and even the Americans believe that. But if you look into the inclusion criteria for HPV positive oropharyngeal carcinoma in Europe, is slightly different. So they do a specific test. But in if you look into the American College of Pathologists guidelines, you can see that for a P16 for oropharynx, if the P16 is positive, then they consider HPV positive disease. I agree that. Any other questions? Yes, one question. Any provision for screening and prevention of HPV positive oropharyngeal carcinoma? Screening, if you want to screen a disease, then there are certain criteria. One, the prevalence should be very high. Number one, we should have a very small, cheap test. Three, we need to have, it should be accessible. Four, we should have data that it will improve survival. So we need more long-term data. Regarding vaccination, this is again, it's a big question in the front. We do not have any hardcore data. As of now, like for carcinoma, right, for a cervix, we need more, we need to read more. Okay, yes, in node positive, unknown primary and P16 comes as positive, would you include oropharynx in high risk or intermediate risk CTV? That's again a matter of debate, because if you include the oropharynx, the questions are, one, whether we need to include the whole of the oropharynx in high risk, because the most common sites are in the order these the tonsil, base of tongue, then the soft palate. So we may not be able to do that. But an amicable solution is that you give an intermediate risk to at least a 60 grade. Okay, that is the how common is HPV associated head and neck squamous in your institution? We are evaluating our own data. It's around 30%. The prognosis is still better in patients having tobacco or smoking history. Yes, that is one of the. If a patient is having HPV positive and smoking, and if it is less than 10 pack years, they have a good prognosis. And the best prognosis with patients who have less than 10 pack years and patients who are P16 positive and up to nodes up to N2A. This was having the best prognosis. So if a patient is having more than 10 pack years, and if that patient is having intermediate risk if it is P16 is positive, but still they have a poor outcome. Yes. Yeah, that's a very good question. Do you practice induction chemo for HPV associated large nodal disease? To be very honest with you, yes, because if a patient is having, because most of them have a small primary and large nodes, especially, and these patients are young patients, most of them will undergo the IMRT. If the patients, then most of the patients may require an adoptive IGRT. So personally, what we do is you give one or two cycles of induction chemotherapy. you adopt, then you do an IGRT rather than doing an adoptive IGRT. Thank you very much. If you have any other questions, you catch me either through WhatsApp or through mail. I'll be more than happy to answer your queries. And we will have another session maybe after 1 or 2 months. Thank you very much for your patient listening. Again, I thank for the invitation. I sincerely thank all of you. All the best for your exam. Thank you very much.
Thank you, sir. Thank you so much.